Hi there. I'm Dr. Laura Robin, and I really want to welcome you today and thank you so much for coming. I am a DO. I've been in practice for a long time. I'm board certified in family practice and preventive medicine and public health, and also in integrative and holistic medicine. I'm one of a relative handful of doctors who in the 1990s started studying integrative and functional medicine with the pioneers like Jeffrey Bland and Alan Gaby, Jonathan Wright, Andrew Weil. And sometime during the pandemic, it became very clear to me that my next and likely final mission in my career is to be a cog in the wheel of paradigm change for medicine and for our country. I think that it's clear to many of us that conventional medicine, although it's life-saving in many respects, and it has taken the practice of medicine away from a patient-centered, preventive, logical approach, and it's taken it to a top-down, insurance and pharmaceutical-led, symptom-based, fast food type approach to illness and disease. I think it's clear to many of us that this paradigm really needs to change. So here I am in my tiny corner of Oregon, just one person on a computer with a small team. And I've decided that it is my mission to be part of the change. And there aren't many of us who had the opportunity to start training and practicing 30 years ago when functional medicine was pretty much in its infancy. So it's my mission now to take my 30 years of practice, my thousands of hours of clinical training, and my hundreds of hours of business coaching, and to help other practitioners find the love and the spark and the impact that this type of care can have on both their patients and on their practice team. With that, I want to welcome you to the second of three-part webinar series. And it is today we're going to be talking about the role of thyroid, adrenals, and sex hormones in fatigue. And as I was talking about in my last webinar, fatigue is a major issue. About 30% of adults complain of significant fatigue in their lives. I remember in my early days in practice when my patients would come and complain of fatigue. After a while, I got tired of hearing it. And I actually, it was one of the things that I just didn't even want to think about, wanted to blow off, because it's a really big topic. I now look back and think that my patients actually, I did them quite a disservice. And through the years, I've learned more and more and more about fatigue, the causes of fatigue, and I've learned to help my patients work through them, work through those root causes in a systematic way so that we can get to the bottom of things and we can turn them around. And that's really what functional medicine is all about, is really not only giving the medications from, like using a top-down approach to help people with their symptoms, sleeping medicines for sleep and blood sugar medicines for blood sugar, that kind of thing. But functional medicine is all about really helping people dig to the roots of what's going on in their bodies, so that they can actually turn things around at the cellular level and at the molecular level, and they can really turn their health around for real and for good. I'm happy to say that I had a fun last 8 years in my practice, really creating a systematic way for people to do that. And if you are interested, you can check out my website. We can have a conversation about what I do. So the endocrine system in our body is ginormous. It is everywhere. Endocrine system is a system in our bodies that create and circulate our hormones. And we have more than 50 hormones in our bodies, and they're really kind of like the messengers. They do so much. They're responsible for so much, but they're kind of like the quiet messengers that kind of just travel around. These hormones are made in many different places in our bodies, and these are some of those places. And then after they're made, some of them need to be activated, or they need to be changed in some way so that they can become more active. It's a very, very complicated system and a beautiful system. I chose just 3 areas of hormones that have a huge effect on energy and fatigue in our bodies. So that's what we're going to talk about today. And each of these three systems are controlled by a positive and negative feedback loop called the hypothalamic pituitary axis. We have our hypothalamus up in our brain, also our pituitary gland in our brain. The hypothalamus sends releasing factors into the pituitary or toward the pituitary. The pituitary is then signaled to send releasing factors to the glands, or adrenals and ovaries or testes. And those signals, the TSH, the FSH, the LH, the ACTH, signal those glands to make hormone. So we're going to be talking about these hormones, how their balance or imbalance can relate to energy in our bodies and what we can do about it. So just to show you, this is a complicated little slide here, but it's just to show you that the endocrine system is really complicated, and we see many different glands in here, and I've highlighted the ones we're going to be talking about, but this, I just wanted to show you how everything affects everything else. If you look at the thyroid in the middle and look how many lines there are going to it, you can see that it's affected by the adrenals, it's affected by the pancreas, it's affected by the gonads, and if you look at any of the glands that we're going to be talking about, there's just such an interconnectedness, and a lot of us don't realize that, and this is a really important piece of trying to tease out the puzzle a little bit. So we're going to start with the thyroid gland, which of course is in our neck. It sits right under our thyroid cartilage. The thyroid gland is responsible for making thyroid hormone. 93% of the thyroid hormone that it makes is in the form of T4, which is a much less active hormone than the activated form, which is T3. The thyroid makes 93% of the hormone that comes out of the thyroid is T4, only 7% is T3. And then the T4 that comes out of the thyroid is then converted. It's converted in the liver, in the gut, in other tissues, and it's converted into T3, which is considered the active form. There's still a lot of argument about what's considered normal and what's not considered normal. When we look at hypothyroidism, low thyroid, it's 8 or 9 times more common in women than it is in men. About 5% of the US population is diagnosed with low thyroid function, but it's estimated, and there are many estimated, that another 5% of people in this country are hypothyroid, but they don't yet know about it. And this is actually a common number. It's probably related to how our system works, but it's also related to how the conventional medical world actually looks at thyroids. Hypothyroidism is age-related, much less prevalent in younger people, and much more prevalent as we get older. 21% of women greater than 74 years of age are hypothyroid. The other problem in this country, and with it's part of our medical system, and also with the discrepancies in how doctors are actually thinking about treating hypothyroidism, is that 30% of people in our country who have overt, and I'll explain that later, but have hypothyroidism that everybody would agree on, remain inadequately treated even after 2 years of therapy. We wonder why so many people are walking around tired in this country. This is one of the major reasons that we see a lot of people walking around tired. That's why I'm spending a little bit more time on it. And then a third of patients who are quote unquote adequately treated for hypothyroidism still exhibit symptoms of hypothyroidism. And that means that they are likely not being adequately treated. It could mean that they have other reasons for being fatigued or for having those symptoms, but it very well may mean that they are undertreated. So the thyroid hormone is like the gas pedal in your car. It regulates metabolism, it regulates temperature, regulates cerebral function, and it actually affects every single cell in the body. When I think about the thyroid, I think about Zootopia, the animated movie Zootopia, and the sloths, just like how slowly the sloths do everything. Sloths are very slow animals, and they remind me of someone who is hypothyroid and who is having symptoms because everything seems to slow down. Fatigue is the most common symptom with hypothyroidism, and brain fog, it goes right along with that. Also, because metabolism slows down, people gain weight. Because things are just slowed down, people are depressive, and they may have cognitive changes. They may have neurologic dysfunction, as well as, thinning hair, brittle nails, that kind of thing. The conventional thyroid evaluation is to get a TSH, and if you're lucky, to get a T4. And when I say conventional, this is the conventional world. This is what insurance is willing to pay for. This is what most doctors order. I am sorry to say, and part of the reason I'm giving this talk is that that's not enough. As we learn functional medicine and we learn really the evidence-based information that is out there, the fact that most doctors only do a TSH and T4 is actually somewhat criminal, and is definitely one of the things that is leading into the low diagnosis rates and the poor treatment. Functional medicine looks at thyroid in a much more robust way. There are 6 or 7 thyroid tests that we do, and we also pay attention to nutrient levels. This just came from Rupa Health, but I wanted to just show kind of these functional medicine tests, and also the ranges that we like to look at when we're evaluating somebody's thyroid. As you see, there's a standard reference range, and there's also an optimal range. So when we look at the standard reference range, this would be the range that that conventional medicine would agree on. And the optimal range is more the range that functional medicine folks look at. And it, as you can see, it's a more narrow range. And in some cases it's the same, but in other cases it's a more narrow range. The other thing is that we are from a functional medicine perspective, are a lot broader, more broad on how we look at thyroids, and what we consider to be hypothyroid. And also we know that that what we're seeing on paper, if it may not be the be all and end all of how we are evaluating a patient, is that there are some symptoms that are very much attached to hypothyroidism, and we really need to pay attention to those. And from a functional medicine perspective, we find it very and most important to actually treat the patient as opposed to treating their numbers. But there are 2 different kinds of hypothyroidism, and this is from a conventional standpoint. From a conventional standpoint, people are not considered to be hypothyroid unless they have a TSH, a thyroid stimulating hormone, that is more than 10. And whereas there is also something called subclinical hypothyroidism, which is defined differently in different circles. So the conventional way of defining subclinical hypothyroidism is somebody who has a TSH between 5 and 10, and they're having symptoms. But from a functional perspective, 5, and I've got to tell you from personal experience, with myself and also with my patients, if somebody has a TSH of 5, they're most likely feeling it. I think I've met one person over 30 years who had a TSH of 5 and actually did not have symptoms of hypothyroidism. So as I said, 30% of the people out there are running around tired, and a TSH of 5, when I see that, I feel strongly to look closer at their thyroid. From a functional medicine perspective, anything over 2, especially if they're having symptoms, we need to be taking a look at them. And also there's more and more research coming out that says that TSH is becoming less and less of the gold standard to look and evaluate a thyroid, that there are a lot of people who have thyroid dysfunction who may have completely normal TSH and completely normal thyroid hormones in general. So why does thyroid function get low? Well, many reasons. So when I was in conventional medicine, I didn't really, we just thought, okay, thyroid function's low, thyroid function's not low. If thyroid function's low, we treat. And in conventional medicine these days, we've determined that the most common reason for hypothyroidism in adults is an autoimmune thyroid issue. So we'll talk about that in just a little bit. Hashimoto's thyroiditis is the most common autoimmune hypothyroidism. There are lots of things that can happen with the thyroid to make the thyroid not work well. So for one, we start at the top here. We start where the signaling starts, and the hypothalamus can be affected by leptin, by insulin resistance, and also by inflammation in the body. So sometimes that initial signaling is not happening, or the negative feedback loop, or positive, negative, it's actually negative feedback loop to the hypothalamus is not working properly. So if the signaling there is not working well, then the pituitary is not going to get signaled, and then the actual gland is not going to get signaled. So hypothalamic dysfunction is not uncommon because we see so much insulin resistance and we see so much inflammation. The number two cause, just below autoimmune causes of hypothyroidism, is pituitary dysfunction. Is that once the pituitary gland in the brain gets the signal, it's not creating the hormone to then signal the thyroid gland to produce more thyroid hormone. We need to be looking at all these different possibilities because these all affect the labs. And when we're reading the labs, and maybe the labs are not super clear, or they just basically primary hypothyroidism, we need to actually look at other things. Another main reason for hypothyroidism is a decrease in thyroid hormone production, and that can be that the thyroid is being destroyed by antibodies, by autoimmune issues, can be destroyed by other things. We consider it actually the canary in the coal mine because it is the most sensitive gland in the body to inflammation and to any other problems in the body. It is very easily tweaked and very easily slowed down, shut down. Also, we require certain nutrients to make our thyroid hormone. And if we don't have those nutrients on board, then we can't make the thyroid hormone, or we can't convert that inactive T4 to active T3. Another issue is receptor resistance, is that just like the sugar insulin system in our body requires the insulin receptors on the cells to be working and to be able to connect with the insulin, thyroid requires the thyroid receptors on the cells to be open and to be able to connect with the thyroid hormone in order to plug in and for the thyroid hormone to be able to do what it does. So that's another super important thing to look at. And then also the thyroid is carried around by thyroglobulin. So there are certain issues that can make elevated globulin levels, particularly if we're not completely in balance. So those elevated globulin levels can then keep the thyroid hormone bound so that it doesn't free up to then connect with the cells. So let's talk a minute about Hashimoto's thyroiditis. So there's a lot of discrepancy about what's considered to be autoimmune thyroid, what's considered to be Hashimoto's, but conventional medicine has agreed that at least 5 to 10% of all people who are hypothyroid do have an autoimmune thyroid condition. And Hashimoto's is the most common cause of hypothyroidism in the developed world in people over age 6. you measure two types of antibodies. Basically, what autoimmune hypothyroiditis is that our bodies have created autoantibodies against thyroid and thyroid function. So we've created autoantibodies against TPO and also against antithyroid globulin. And TPO is thyroid peroxidase. So those are the two things we measure when we're looking for an autoimmune thyroid. But the interesting thing is, even though only 5 to 10% of people with hypothyroidism are considered to be autoimmune or Hashimoto's thyroiditis, the TPO antibody is actually present in more than 95% of patients with overt hypothyroidism and 50% of patients with subclinical hypothyroidism. It's even present in 10 to 20% of the background population. The thing is that the standard antibody level to diagnose Hashimoto's in the conventional world is 35 IUs per milliliters. That's a big number. That's a big level of antibodies, which it's a little bit crazy. Functional medicine doctors in the functional medicine world, if somebody actually has TPO antibodies at all, like if their level is greater than 2, we actually consider that they have an autoimmune thyroid going on, because they are making antibodies, even if their antibody level is super low. Okay, so here, when we're looking at our thyroid hormones, one huge thing to remember, and I'm going to bring this up over and over again, when we're talking about hormones, normal does not mean optimal. Okay, when we're actually treating any thyroid, we want to pay attention to the range of the hormone that we're looking at, but we also don't want that to be the main thing that guides us, because when somebody has Hashimoto's, they have an autoimmune thyroid. So now we're arguing that it could be in 5 to 10% of our hypothyroid people, but it also could be in 95% of our hypothyroid people, is that when there are circulating antibodies, it blurs the picture a little bit. Yes, it's important to be looking at certain ranges, but just because somebody's in a certain range, in the right range or in the normal range, does not mean that they are optimally treated or optimally corrected. And that goes for really any of these hypothyroid issues. So in the autoimmune thyroid, what we want to do is we want to treat the patient as we would any autoimmune syndrome. Hashimoto's is one of the most, if not the most common autoimmune syndrome. But like any other autoimmune syndrome, it takes 3 things in the body. One is that some genetic predisposition to be one of those people who happens to make more autoantibodies. And then the other thing is that most often what we see an inflamed gut and leaky gut. And that seems to be a huge precursor to autoimmune issues. And then the third one is a trigger, and it can be a trigger of any kind. It can be a huge stressor or infection or a toxic exposure, or many things can kind of put people over the edge. So when we treat an autoimmune thyroid, we want to treat just like we would treat any autoimmune syndrome. So the first thing we want to do is we want to clean up the gut. We want to treat the gut. We don't want the gut to be inflamed, and we don't want the gut to be leaky. And the next thing we want to do is we want to treat all causes of inflammation. And I've got a cat. And then the next thing we want to do is, and in treating the gut and in cleaning things up and looking at for causes of autoimmune issues, we want to look for food allergies, sensitivities, intolerances. Another thing that we want to, especially with thyroid, is we want to be careful about gluten and dairy. So a lot of people have gluten or dairy sensitivities, right? That means that they make antibodies against gluten or against dairy, all right? The thyroid shares molecular structure similar to that of gluten, that of dairy. So if we have molecules that are circulating that are antibodies to gluten or to dairy, then they may connect with the thyroid molecules and be a part of that autoimmune problem. If you haven't heard of low-dose naltrexone, I don't have the time to go into it and explain it, But naltrexone is Narcan. It's what is given to people when they're overdosing with opioids. It is a very, very potent medication that connects. It just has a very high affinity for the opioid receptors. And about 30 years ago, it was found that in very low doses, this connection to the opioid receptors can really help the body to regulate its own immune system. So when we have people with autoimmune issues, giving them a low dose of naltrexone, generally super safe, very low side effect profile, can work really, really well in helping them to helping their body to kind of tamp down the autoimmune response. And it's important to treat autoimmunity because at least 50% of folks who have one autoimmune issue actually progress to go and have another. So I promised you this little slide on molecular mimicry. If you just were to hold your hand in front of your face so that all you're seeing is the bottom third of this picture, where you're just seeing the neck and the hair or fur, if you look at that in that way, you can see that they're really super similar. You can't really tell which one is the dog and which one is the girl. And that's the whole idea of molecular mimicry, is that these molecules are circulating. The gluten, the antibodies to gluten, antibodies to dairy are circulating, and the thyroid looks very similar to those antigens, so that the thyroid then can get attacked in an autoimmune way. So key points for working with hypothyroidism is do comprehensive testing, at least initially. One of the things I talk about in my immersion course is how to get tests so that your patients are not having to pay thousands and thousands of dollars outside of their insurance for them. There are ways to do testing, cash testing, that are super inexpensive. For example, the top four, the TSH, T4, free T4 and free T3, I can get them for $24.50. And I know that it's about $450 if you go through insurance. But it's really important to get these because you cannot rely solely on a TSH. You want to prioritize symptoms over numbers. When you're treating, you strongly want to consider combination therapy, not just levothyroxine or T4. You want to consider using T3 either in a form that you can get that is made in a lab, or you can actually use a glandular. If you're testing a free T3, you want to do it fasting or at least 6 hours after the dose. And then you want to remember all those key nutrients. And you also want to presume autoimmunity until proven otherwise. So that's a whole other course to how to look at labs, how to treat, how to really work with somebody who is hypothyroid. So we don't have the time to go into that right now, but just Monday Morning Pearls. And this talk will be available on YouTube in the next couple of days so that you can review it if you want. But consider hypothyroidism in anybody with symptoms, but also consider hypothyroidism in anyone with a TSH greater than 2. And I know that's not conventional, but that is what I have found in my practice. And that is really what most functional medicine folks will do. And you want to do the comprehensive testing, at least initially, and just know, because there are all these different ways that things can go off, that even though you need to test, the testing is not always going to be detecting the problem. You want to treat to symptoms. So the research shows that treating to a TSH of 0.5 is safe. It does not cause any increase in cardiac symptoms, which is the biggest concern. No increase in bone loss, which is another concern. There are some studies that say that treating to 0.25 is okay, but that's kind of, it's safe to say that treating to 0.5 appears to be safe. Of course, go by the symptoms. If your patient is having palpitations, you cut back and you slow down. But when you're treating somebody, start low, go slow, always the safest way to do things. But really, you can test every 4 to 6 weeks, and you can adjust things based on symptoms, based on their numbers. So also consider adding the T3. And if you're considering that they might have a thyroid issue, also consider that they may have an adrenal issue. So here we go for the adrenals. So the adrenals, your adrenal glands, they sit right on top of your kidneys. They're these tiny little glands that are about the size of a walnut on top of each of your kidneys, and broken down. There are two pieces to them: the cortex, which is the outside, and the medulla, which is the inside. And they make some super important hormones. So the first thing is and this is a gross simplification because there are other hormones that come out of here, but the adrenals make adrenaline, which is our fight or flight, we're being chased by a bear kind of hormone. But what we're going to be talking about today is what's made in the cortex, which the predominant hormone that is made in the cortex is cortisol. And we're also going to mention DHEA. But cortisol is just like the thyroid is your gas pedal. The cortisol is your ignition switch. It's your get up and go. It helps the body to rise to whatever occasion happens to be happening. So let's say that you have to wake up at 9 o'clock in the morning. You have to give a talk online to a bunch of people. Hey, that's my cortisol working. My cortisol is getting me up and making sure there's plenty of blood flowing to my brain and my eyes and my muscles and getting me ready for this. It also will help us if we're sick or if we're tired for another reason, like our thyroid isn't working properly, or our other hormones are off, or we have an infection, or our mitochondria aren't working so well. So the cortisol is like the last thing. If nothing else is working, those adrenals are going to shoot out that cortisol, and it's going to make your body get up and go. So that's a good thing. Cortisol is a great thing. But on the other hand, the whole system is a little bit fragile with the amount that our 24/7 world is making us get up and go and get up and go and get up and go. We're finding more and more people are having difficulty with their adrenals. All these things: carbohydrate, protein, fat metabolism, fluid and electrolyte balance, and affects the heart and cardiovascular, and also our sex drive. These are all the things that affect the adrenals. So look at all this stuff. So we see a lot lifestyle and stress, things that cause emotional stress, but we also see things that might be happening in our bodies, like we're healing from a wound, or we have allergies, or we have an infection, or we're taking medications that are slowing down our heart rate or slowing us down in some other way, and then our adrenals need to kind of kick in. Or we're fighting toxins, or we're drinking too much coffee, or we're eating too much sugar, or we're smoking. Many things affect the adrenals, including lack of exercise and also excessive exercise. So and our adrenals, when they get called, they're going to work, and they're going to work as best they can. And again, it's that feedback loop. The hypothalamus gets a signals the pituitary, which then signals the adrenals to get to work. What happens is that we keep going and going and going and going, and we'll see that in a minute. I just wanted to show you the thyroid adrenal connection is that stress affects both the thyroid and the adrenals. But the things that I want you to look at here are these areas of inhibition, so that when the adrenals are being called on, that actually inhibits the thyroid. And when cortisol is created, high levels of cortisol also negatively affect the thyroid. So these are things, as I said, everything is interconnected, and just wanted to key you in on that. So what happens is our adrenals were working, and then our adrenals kind of get pooped out. Well, and I'll show you that in just a minute. But the symptoms that go along with our adrenals having an issue are a little bit different than thyroid. I mean, both cause fatigue, and some forms of adrenal fatigue can just cause plain fatigue, like hypothyroidism. They both can cause weight gain, a little bit in a different distribution. Hypothyroid tends to be kind of everywhere. Adrenal tends to be more like belly area, predominantly. They both can cause disrupted sleep, and adrenal fatigue can cause either warm or cold temperature, as opposed to hypothyroidism, which is generally cold. And people who have adrenal issues, they might look normal, but they generally don't feel so good. And I was one of these people. I'm good at talking about fatigue because I've had many issues. I've gone through many of these things in my life. And when I was medical director at the Student Health and Wellness Center at our local university, I was also a mom of a little kid, and I was also a president of some other major organization, and it was a lot for me. And one day I was standing with one of my patients, and I all of a sudden, it was kind of like the key in the ignition just turned right off. Like it was like the pinball machine, if you're old enough to remember, the pinball machine just went on tilt. And I all of a sudden got lightheaded, and my get up and go got up and went, and I had to sit down, and I was embarrassed because I was in with the patient, and I was supposed to be the one that was helping that patient, and that patient kind of had to wait for me to gather myself. And that was the first of many episodes like that I finally realized were I had just burned myself out, so to speak. So let's take a look at what adrenal testing looks like when that is happening. This is an adrenal stress index. When we test adrenals in conventional medicine, we test a blood test, and it's a morning cortisol level, which I find to be relatively useless unless there's a major issue with the adrenals, and unless adrenals really are basically not working. Because when you go to get your blood test, cortisol, it responds to stress. So this is a normal curve, okay, of cortisol. And the green bar is the within normal limits curve. An adrenal stress index that is showing 4 points, 8 a.m., noon, 4 p.m., and midnight, that follow the normal curve. So this person has their highest cortisol, which is the way it's supposed to be, is first thing in the morning. That's what wakes you up. That's what takes you from sleep to wake. That's what gets you out of bed in the morning. That's why a lot of us are more clear and have more energy first thing in the morning. And then it just follows a slow curve down throughout the rest of the day. Let's say that we're having a problem. We have trouble getting out of bed. We have trouble waking up in the morning, but our doctor gives us a prescription to go get our blood drawn. So we get up first thing in the morning. We have to get dressed. We may take a shower. We get in our car. We drive across town. We're anticipating a blood draw, and then we get our blood drawn. And so how many stressors do you think are in there? So in my opinion, and what it seems to be, is that blood test is not as accurate as it could be when we're really trying to look for adrenal dysfunction. So we use saliva. There are other ways of doing it as well, but saliva's been around really since I started doing this stuff back in the 90s. So this is a normal curve. What typically happens is there are 3 stages to the adrenals kind of getting pooped out. One is that we're just pushing cortisol all the time, and our adrenals are actually rising to the occasion there. So our adrenals are putting out more cortisol because they're trying to keep up with us, trying to keep up with the world, okay? But then what starts to happen is things start to get a little wonky. The whole HPA axis just starts to not work so well anymore, and the adrenals start to not be able to create the hormone quite as well anymore. So what we see a combination that some of these things are normal range, some of them are actually high normal, and some of them are low. So this is a perfect example of somebody who might be having a lot of trouble getting out of bed in the morning, and then they're also having trouble getting to sleep at night because everything is just a little bit wonky. And then this is the adrenal fatigue stage 3, where just the adrenals are just like, we're done. We just have nothing left. I call this lovingly a flat line, but it's actually, it is dangerous. You need cortisol or you will die. But this even is something where somebody might end up, they may actually end up testing with a blood test to be low, but they may actually end up not and have a curve that looks like this. So when a curve is like this, the good news is that most adrenals can heal, but it takes time. It can take a year or 2 for adrenals to come back. So giving them the nutrients they need, definitely taking the rest. I have taken people just completely off of work, off of all duties for months in trying to heal their adrenals, and it works, but you really kind of have to do that if you want them to come back again. And there are many herbs that are really helpful to help the adrenals replenish themselves. And you can also use some help. There are some glandulars. There's also hydrocortisone is a treatment that we can give to people to give them a little boost during the day. But the good news is that adrenals in general can heal. Thyroids, it depends what the problem is. You can definitely arrest an autoimmune issue. You can arrest the thyroid having more and more difficulty. Whether the thyroid can actually heal or not, it really depends on what the problem is. But adrenals, they can heal. It's really nice. DHEA is also produced by the adrenal glands. It's an androgenic hormone. It's made from cortisol, and it's the most abundant steroid hormone in the body. And it can convert to estrogen, testosterone, progesterone, and it really can, when it's low and we replenish it, it can really help with energy. And also there are studies that show that it can be really helpful as far as longevity. And there are some studies in men that show that it can help with all-cause mortality and morbidity as well. We are moving fast through this, but I wanted to talk a little bit about the sex hormones, and because the sex hormones can play an enormous role in fatigue. So estrogen can affect our serotonin levels and our receptors, our endorphins, our metabolism, our cognitive function, our mood. And so low estrogen is associated with lower energy, and that is often we see this in menopause particularly, but is improved by estrogen replacement. And fatigue is also can be a symptom of estrogen dominance, which we'll get to in a minute. Progesterone is the hormone of pregnancy. It's the hormone of, it's just a beautiful hormone, happiness in pregnancy. And but it also has a little bit of a sedative effect. And low progesterone can be a cause of sleep disorders. And I see this a lot in menopausal women, is that they are just not sleeping. You add a little bit of progesterone and it just changes their lives. A low progesterone to estrogen ratio is called estrogen dominance, and that can affect many aspects of metabolism. So what we do to check progesterone to estrogen ratio in menopausal women, we just get a progesterone and estradiol level. In cycling women, we usually do that on day 19 or somewhere right around there. And then we just plug it into a free calculator online, plug in the progesterone, plug in the estradiol, and we get a ratio of progesterone to estrogen. So the ratio 100 to 500 is normal. Okay, it's approximately normal, and then below 100 is considered to be a sign of estrogen dominance. What is the most common cause of estrogen dominance? Is stress, believe it or not. As I said, the adrenals are like the bottom line. Like, if nothing else is working, those adrenals are going to get that cortisol out, and they're going to help us to keep standing, right? So if you look at these pathways, cortisol is made directly from progesterone, okay? And if you look all the way up here, the original molecule that goes into making all of these steroid hormones, which are all of these, is cholesterol. So there are different pathways. So cholesterol can turn into DHEA, and the androgenic hormones like testosterone and estradiol also turns into estradiol. But when we need cortisol, what happens is that the pathway that moves toward cortisol is the one that is everything is kind of moved in that direction. So we pretty much bypass the circulating progesterone in favor of cortisol being sent out there, because it's like, okay, front line, cortisol, we need cortisol, we need cortisol, we need cortisol. We do not need a pregnancy. We do not need sex hormones right now. We need cortisol. This body needs cortisol. So, and that's what happens. So our progesterone levels are not able to keep up with what is needed to be able to balance at the estrogen and estradiol levels. So then somebody becomes estrogen dominant, where they have too much estrogen as compared to the progesterone. They still may be low in estrogen because all this stuff is happening. They still may be low in estrogen, but relatively they're even lower in progesterone. And what that causes is it causes anxiety, mood swings, depression. It's probably the main reason for postnatal depression, and decreased sex drive, blah, 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 and fatigue. Fatigue is a major symptom of estrogen dominance, but we also see heavy periods, worsening PMS, sleep disturbances, headaches, migraines, mood changes, fat gain, all of this kind of stuff. So what happens though is there's this vicious cycle that happens. So when somebody's tired, they're going to have an increased cortisol requirement. Okay, they're stressed, they're fatigued, and so their body's going to make more cortisol. So we call that the cortisol steal or the progesterone steal. Some people call it the pregnenolone steal, but it's the same steal. Okay, and it's not really a steal, it's just that the body decides that it needs to move in a certain direction as a priority, and then that decreases the progesterone level and causes estrogen dominance. But then the estrogen dominance can then lead into thyroid irregularities, sleep disturbances, and all that stuff, and causes fatigue, and which makes the cycle worse. And I am amazed. If there's one pearl you guys take home from this today, it's like, there is so much estrogen dominance in our world. You look at the women who are having horrible PMS, menstrual migraines, who are out for 10 days every month from symptoms of their periods, postpartum women who are depressed, and also menopausal women who just are having all of those signs of estrogen dominance. We need to actually pay attention to this because it's such a huge thing. And then on top of that, you add the xenoestrogens, all the pesticides and herbicides and everything, which makes the estrogen levels even higher. That even makes it worse. So, this is just up here to show you that estrogen dominance and adrenal fatigue are similar. They can look similar. They are different, but they look similar. And I wanted to show you. Okay, and we're going to go into testosterone deficiency for women. Before we do that, I just want to say that, everything is interconnected, right? And everything, there are lots of overlaps. So things can look similar. We need to evaluate it all. So let's talk about testosterone or androgen deficiency in women really quickly. Decreased energy levels, sexual desire, libido, muscle weakness, all of these things. Women make testosterone. We make about 1/100th of what men make, but it really does very much the similar things. So low testosterone in men and women related to fatigue can cause fatigue and depression, weight gain, insulin resistance, elevated cholesterol, muscle loss or weakness, decreased libido, decreased motivation, coronary artery disease, and cognitive decline. These are all things that are associated with low testosterone, not only in women, but now we're going to move over to men. And so testosterone does very similar things in men and women, although women make a lot less of it. So the same type of a cycle happens. That low testosterone can cause fatigue, which then causes the increased cortisol requirement, and then causes the cortisol steal, which then leads to low testosterone. Same kind of cycle. So what causes low testosterone in men? Well, elevated cortisol or cortisol steal can both cause it. And relatively low testosterone due to higher estrogen levels or xenoestrogen, or another big thing that I will talk about in my course in September is high sex hormone binding globulin, which comes with insulin resistance and adipose and all of these, and stress and all of these kinds of things. Age, medications, again, the HP axis dysfunction, and low thyroid, and also primary hypogonadism. So in testing and treating hormones, just again, normal is not optimal. So we're looking at ranges, right? We're looking at, when we get tests, we find people in ranges. And just because they're in that range does not mean that everything's okay. So this is an example of a testosterone in a normal versus optimal situation. I'm just going to give you this example just so that you know this happens with thyroid, this happens with estrogen, progesterone, testosterone in women. This is testosterone in men. Normal is between 200 and 800, okay? So that's a ginormous range of what's normal. And the insurance companies say in order to be diagnosed as having low testosterone, a man's testosterone level actually has to be below 200 on two separate occasions, their total testosterone. Okay, which to me, I mean, it's a little bit crazy because, like, what happens if your level is 250? I remember this guy named Jeff, 50 years old, came in and his get up and go, got up and went. He couldn't get off the couch. He was just, muscle mass was going down. He was tired. He was not motivated. He just told me he lost his mojo, right? Low libido, the whole thing. So we tested him. He was 250. So he would be considered within normal limits, right, with any insurance company, but we gave him a little bit of testosterone. We brought his testosterone level still within normal limits, but up to 650. It changed his life completely changed his life, changed his muscle to fat ratio, changed his energy, changed his motivation, changed his libido, changed his mood, changed everything. So when we're looking at things, we really need to pay attention to that something can be within normal limits, but not optimal. And this is one of my biggest pet peeves about Western conventional medicine. One of my biggest pet peeves is that they say, oh, you're within normal limits, so you're normal. And please, one of the biggest pearls I'm hoping to send home with you is please pay attention to the patient. Please pay attention to their symptoms, and please pay attention to the fact that normal it doesn't mean anything. It just means it's what is right for that particular patient. So yes, bioidentical hormone replacement. We have no time to go into that today, of course. This is going to be another talk down the line. This is something that I'm going to cover in my fall immersion course. It is a can of worms, but a very worthy one. It is bioidenticals have been kind of kept out of the mainstream, mostly because of money, insurance, pharmaceutical companies and the like. It's a long story, but reality is that bioidenticals, many studies behind them, they are safe, they are generally safe, they are generally effective, and they change lives. They change lives. This is in the thyroid world. It is also in the sex hormone world, both for men and women. So if you haven't studied bioidentical hormones, I recommend that you do. I'll be jumping into it during the immersion as an introduction. But if there's a course you can take, A4M, IFM. I know, there are others. I think Bill Clearfield might be on the line. He does a course as well. And so please get that training. So this is just a picture that shows our adrenals, our thyroid, our female hormones, male hormones can be in there too. But look at all the ways that each one affects the other. So this is the big thing that I wanted to say today, is that hormones play an enormous role in fatigue and in the causes of fatigue and in treatment of fatigue. We need to look at them very carefully. We need to look outside the box, look outside the conventional box when we are looking at them. And we need to pay attention to how everything affects everything else. Don't have really time for this. I want to honor your time, but the pineal gland away in the head, in the brain, in the middle of the brain, makes melatonin. Melatonin is an overseer of all the other hormones in the body, and it also the key behind our circadian rhythms. And melatonin decreases with age. If somebody's not sleeping, if they have a low melatonin level, you may want to bring their melatonin levels up. And again, this is something I'm going to cover later, but melatonin is really important overseer of all these other hormones. So more Monday morning pearls for you is that in hormones, everything affects everything else. Normal is not necessarily optimal, so please take that home. If somebody's tired, think about their thyroid and their adrenals and their sex hormones, and remember to look for the root causes of these issues, not just the fact that their numbers are off, but like what is causing those numbers to be off. And remember nutrients, remember, food as medicine, remember nutrient supplementation in helping people to get what they need to get these hormones made and working properly. And when everything comes into balance, when your hormones are in balance, you're good. Believe me, you're going to have some very happy patients. So please remember that. Okay, so I want to thank you for being here so much. I want to tell you about just a couple of things that I'm doing. So as I said, my mission is really to help other clinicians get up and running with functional medicine in their practices. I do not pretend to be the IFM or the A4M. I don't go into that kind of detail, but as I have been speaking with hundreds of doctors, nurse practitioners, and PAs over the past several months, what I've really seen is that there is a need, not for the 2 to 3 year, in-depth programs that are available from these wonderful gold standard organizations. But what's really needed is when people want to get into practice, they don't know where to start. They don't know what to do on day one. They don't know where to get how to set up their practice, how to order labs, how to interpret labs, and how to talk to their patients. And so this is what my mission is. So my mission is to get people up and running in functional medicine in their practices. I've got a couple of things that I'm offering. One is that September, I'm filling a cohort for a 12-week immersion called Elevate Your Impact Immersion. And this is where we're going to master the basics, going from 0 to 60 in functional medicine, root cause medicine, and whole person medicine. And hopefully it's going to give you the tools to quickly get up and running in your practice. And my reason for doing this is I want to be that mentor. When I first went into integrative and functional medicine back in the 1990s, I just ran into my mentor. My mentor ended up being one of my closest friends, and he took me through from day one, how to do it, what to read, where to go, what courses to take, and we did case studies, and he was available for me, and I feel like that's really important, and it really is important to have a mentor when you're getting up and running in functional medicine, because it's complicated, and there are ways to make it simpler. There are ways to prioritize certain things over others. So anyway, I want to be that help. The other thing is that I've created a program called the Total Health Reset, which is an automated program. It is at this moment in time, it's 9 weeks. It's going to be more fluid than that in our second version, which comes out in October. And the purpose is to take your patients through the basics that they need to go through to elevate their level of health from 0 to 60, but it just takes their level of health. We put them through, food allergy elimination protocol, gut repair, learning about toxins and eating well and making those changes. They decrease their inflammation, they boost their nutrients, and it's actually amazing. 80% of my patients got 80% of what they needed just by going through that. And then I had an elevated whole cohort of patients who knew how to take care of themselves, and they felt really empowered, and it just made for a really happy practice. So the Total Health Reset is coming in October. The version 1 is available. So just get on my website, make an appointment, talk to me if you want to talk about any of this stuff. I'm happy to have a conversation, and I've set aside 30-minute increments. Please get in contact with me so we can sit down and talk about your needs and the needs of your clinic. I want to thank everybody for coming, and please go if you need to go, but I'm going to stop right now, and I'm going to answer questions for anybody who might have them.